Hello, I'm Ulf Pape from Germany. I'm a lecturer on further education for physiotherapists, medical masseurs, doctors, osteopaths, and occupational therapists. I currently teach a lot in Switzerland, but also in Austria, Germany, and Spain. My therapeutic work consists of the synthesis of physiotherapy and massage, osteopathy, and manual therapy. In this video, I show you a treatment strategy for subacromial shoulder impingement in the sitting position. This approach can also be used in other positions. My students and I have quick and lasting success with this approach. If you like this educational video, please share it with your colleagues. A shoulder impingement syndrome is a syndrome involving tendonitis of the rotator cuff muscles as they pass through the subacromial space, the passage beneath the acromion. It is particularly associated with tendonitis of the supraspinatus muscle. This can result in pain, weakness, and loss of movement at the shoulder. The affected person can neither optimally underward his arm, bring it into the abduction, nor rotate it outwards. Nor follows a short refresher on the supraspinatus muscle. The supraspinatus is a relatively small muscle of the upper back that runs from the spinous fossa, superior portion of the scapula, to the greater tubercle of the humerus. It is one of the four rotator cuff muscles and also abducts the arm at the shoulder. The spine of the scapula separates the supraspinatus muscle from the infraspinatus muscle, which originates below the spine. The supraspinatus muscle performs abduction of the arm and pulls the head of the humerus medially towards to the glenoid cavity. It independently prevents the head of the humerus to slip inferiorly. Supraspinatus works in cooperation with the deltoid muscle to perform abduction, including when the arm is in abducted position. Beyond 15 degrees, the deltoid muscle becomes increasingly more effective at abducting the arm and becomes the main propagator of this action. I assume that the near test and the painful arc test are positive and that ruptures of tendons have been excluded. I show here a typical impingement procedure. The arm cannot be raised. The patient pulls the shoulder blade up because of the pain. External rotation almost does not work at all. Internal rotation and stretching of the supraspinatus is also hardly possible. This is a typical procedure. Normally, a person with a healthy shoulder can get his arm very far internally rotated and bent behind his back. In doing so, the person would optimally stretch his supraspinatus. Here you can see it. I come from a contraction of the supraspinatus into the stretching position. Why I say this? Important for the therapy are not only the pain and the restriction and the functional direction of movement of the supraspinatus and corresponding myofascial structures, but also opposite directions. Also, it's important that you should briefly mobilize and detoning the healthy side in advance as well. A short pre-mobilization and the detoning of the affected side as far as possible. It's also recommended. You can find much about this in shoulder clips of mine. The treatment steps I will show you now you can and you should also perform in other positions. Now I will show you the treatment in the sitting position. In the sitting position, I recommend that the therapist place one leg on the bench. The placed leg is under the patient's shoulder so that the patient is stabilized and sits relaxed and upright. On the first step of the treatment, we start by pulling the humerus downwards, causing it to slide. The therapist presses the shoulder and the scapula into the depression with his other hand. With a levering motion, the therapist pulls the humeral head out of the joint as far as possible. You see it? I press down the shoulder and I pull. Before we will treat myofascial, in a little moment later return briefly to the clavicle. This is an important intermediate step. We try to release possible small subluxations in the clavicular joints. The brachial plexus can be irritated by these small misalignments of the clavicular joints, which are often present. To include this, try to fix the clavicle and at the same time cycle the upper arm backwards. I can't really prevent the clavicle from moving completely, but I achieve through this maneuver that possible subluxations of the clavicular joints are released. The treatment maneuver can be strengthened if the therapist holds the collarbone with the fingers and the thumbs of both hands and the patient actively circles his shoulder backwards. The next step, the therapist turns the patient's head to the opposite side towards the healthy shoulder. Now we have a pre-stretch position of the levator scapulae muscle located under the descending part of the trapezius muscle. The superficial muscle fascia form a continuum with the superficial muscle fascia of the supraspinatus. Both muscles belong to the same myofascial train. I pull melting in with the focus on the levator scapulae and the supraspinatus over the acromion and the supraspinatus insertion towards the upper arm. I start from the sternocleidomastoid muscle insertion, pull my fingers melting in, up above and below the edge of the skull to the cervical spine. On this way, I melt with my fingers over the first four transverse processes of the cervical spine, that is, over the muscle regions of the levator scapulae muscle. Then I melt in the direction of the supraspinous fossa of the region of the supraspinatus. I continue above and beneath the scapulae spine, melting down to the acromion, where are below the supraspinatus tendon and the bursa are pathologically compressed, causing the impingement syndrome. Then I melt deeply over the muscle insertions as over the major tubercular, the minor and at the middle humerus. Should perform this maneuver 2 or 3 times. In between, I recommend a transverse friction of the supraspinatus and the tubercular of the rotator cuff. A small acupressure of the levator scapulae muscle near the insertion is also recommended. Next maneuver, we perform a strong traction of the arm. The therapist's arm wraps around the patient's arm. The therapist grips in this maneuver the patient's wrist. The next maneuver is very important. The therapist presses the patient's shoulder down with one arm and with his other arm presses the head of the upper arm with a little less power into the shoulder joint. Then the therapist performs a spiral dynamic movement with the patient's upper arm. You move the tip of the humerus as if drawing small figure 8 with it into the shoulder joint, both in writing direction and mirror writing. This relieves the tendon and ligaments in the shoulder joints. With my fingers on the patient's upper arm, I can and should simultaneously perform a transverse friction over the long biceps tendon. Now follow even more important maneuvers. I press the shoulder joint into depression. Then I abduct the arm, whose abduction is restricted as far as possible without pain. I tell the patient to press his arm down for 15 to 20 seconds against the resistance of my hand. Then I check whether the patient can't seem to bring his arm up a little further. This is very often the case. Now the patient should first turn his hand as far as possible in the direction of the supination. This is very little possible with a real impingement syndrome, and therefore a part of the problem. Again, the patient presses his hand down for 15 to 20 seconds. And again, I look to see if the range of motion has improved. Then I instruct the patient to press his arm up against my resistance again for 15 to 20 seconds. After I repeat the same again with the hand turned slightly outward, and then I check whether the range of motion has improved again. Then I do the same with the arm in anteversion. Again, the patient presses the arm down, palm down first, and then up for 15 to 20 seconds. Then against my resistance, the pressure is upward, first with the palm downward and then upward. Again, I check to see if the range of motion has improved. Almost always the improvement is significant. On the next step, the patient leads the arm backwards. First, the patient pushes 15 to 20 seconds his arm forward and then backward. Again, the position of the hand is changed. Then I check the range of motion again. Should repeat these counter pressure maneuvers more often and again show the patient the improvement. On the next step, we try to improve the internal and external rotation. First, rotate the humerus as far as possible into internal rotation. The patient tries to externally rotate his humerus gains resistance for 15 to 20 seconds. Then the therapist rotates the humerus carefully further inward. After repeating the maneuver 2 or 3 times, I turn to the external rotation. I rotate the humerus outward as much as possible without being brutal. Then I order the patient to rotate his upper arm inward against my resistance. Then I rotate the humerus further outward. After few repetitions, the extra rotation also improves in small steps, slowly but sustainably. When the success is obvious, I try to perform the rotation maneuvers with the arm bent as well. This is usually more difficult but not hopeless. When I have performed all the maneuvers, I repeat all the steps again and again. After half an hour, the impingement patients are mostly able to perform normal everyday movements again. When this is achieved, I teach the patients active exercises to solve the problem in a 100% sustainable way. I hope you enjoyed the tutorial. You can find many clips on this topic on my YouTube channel. I teach treatments for shoulder problems also in my professional workshops. Let's go! Find pleasant colleagues and friends and practice the maneuvers. Have fun. Goodbye.